Hi, I'm Dr. Jay Rad, urologist and medical director of robotic surgery at Mon Health Medical Center in Morgantown, West Virginia. Thank you for watching this presentation where I will discuss a common medical condition afflicting most men during their lifetime called benign prostatic hyperplasia or BPH. I am an employee of Mon Health Medical Center and have no affiliation or conflict of interest regarding the topic that I will be discussing here. Most people are aware that heart disease, high blood pressure, diabetes are very common diseases in the US. BPH is also in the top 5 of medical conditions that we treat in men over the age of 50, and therefore we're going to focus on this problem. It is important to understand that BPH is very prevalent. In fact, this disease affects more than 80% of men if they're fortunate enough to reach age 70. Some studies have reported that the prevalence of male lower urinary tract symptoms increases 10% per decade from age 40 on. In these two pictures, you'll see a depiction of normal anatomy and one with an enlarged prostate. The prostate is a walnut-sized organ that sits deep in the pelvis and is located at the opening of the bladder. The tube that empties the bladder, called the urethra, exits the bladder and travels directly through the prostate. As men get older, their prostates enlarge and may kink or compress the urethra, thereby causing obstruction or blockage. Symptoms of BPH are things like urinary urgency or the need to rush to the bathroom, or you may have an accident. Urinary frequency or the need to void multiple times over a very short period of time. A weak stream because of the kinking of the urethra can also occur. Difficulty with starting a stream and sometimes needing to strain to get started are often reported. The need to wake up multiple times at night to void is also very common, and one of the main reasons why spouses bring their partners to our offices as they're awoken by their partners or spouses multiple times over the course of the night. We evaluate men by obtaining their history and performing a detailed physical exam, including a digital rectal exam or DRE. A urine sample is obtained to check for blood in the urine, infection, or other problems that may show up. In some men, we may obtain a PSA or prostate-specific antigen blood test for prostate cancer screening if it's appropriate. A questionnaire is often filled out or administered, which is called the AUA symptom score or International Prostate Symptom Score. This allows us to see in an objective fashion where the patient's symptoms fall, and we categorize the scores into mild, moderate, and severe. This questionnaire may be administered at multiple different times throughout the patient's visits with us so that we can keep track of symptom progression or improvement if a treatment was administered. Once a patient is diagnosed with BPH, then we talk about treatment options. There are typically 4 treatment categories that I discuss with my patients, from least to most invasive. I always start by teaching my patients about behavior modification to control symptoms. These may consist of voiding on a regular schedule to keep the bladder as empty as possible. Other things may include changing dietary habits and reduce foods and drinks that are known bladder irritants. Certain drinks may be very acidic in nature, spicy foods, tomatoes, other foods that I often review with patients can cause irritation to the bladder and mimic the symptoms of BPH or even worsen those symptoms. Discontinuing fluids a couple of hours before bedtime and emptying the bladder right before going to bed can help reduce nighttime voids. So very simple things that can be done to improve symptoms and also perhaps reduce the need to go on medications or have other treatments like procedures or surgeries. Next, we often mention herbal medication as there are many advertisements out there that claim to solve the problem of BPH through herbal medicines. Most of these are safe to take at the recommended doses, and that's why they are allowed to be on the market, but they're by no means regulated like prescription medication. Many studies have looked at the effectiveness of these medicines and found that they are no better than sugar pills or placebos in a lot of instances. Also, I always joke with my patients that if they were really effective, the pharmaceuticals would have bought the rights to these herbals and sold them at a much higher price, perhaps. Therefore, I don't necessarily use this as a treatment modality, even though I will discuss the risks and benefits with patients. There are several prescription medications available that I will briefly discuss on the next slide. In this chart, I highlighted three attributes of these medicines. One is something called the Qmax, which is the maximum urinary flow. A normal flow in a man should be around 20 to 25 milliliters per second. The AUA symptom score, which is the questionnaire that I discussed at the beginning of the presentation. And lastly, the side effect profile, or most common side effects, are listed here. Flomax type medicines are designed to relax the muscle of the lower urinary tract and thereby allow for better flow. Finasteride type medications reduce testosterone levels in the prostate and thereby shrink the volume by a modest amount over the course of 6 to 12 months and thereby allow better flow to occur. These two medicines can be combined, or these classes of medicines can be combined for increased effectiveness, although at the cost of combined side effects. Another class of medication that relax the bladder itself and reduce the symptoms of urgency, called anticholinergics. Also, another class that was more recently introduced, called beta-3 agonist. These can be combined with medicines like Flomax in certain patients to achieve perhaps a little bit better outcome. Lastly, one erectile dysfunction medication, Cialis, was FDA approved if taken on a daily basis to treat BPH type symptoms. As one can see, these medicines improve the flow rate, or that Qmax, by only a very small amount. A couple of options here do not increase the flow at all, and that's the anticholinergic plus tamsulosin of Flomax or the Cialis type medicines. Yet the AUA symptom score reduction, so improvement in symptoms, is also very modest, but can sometimes be more pronounced if they're combination therapies. And some studies have looked at the placebo effect and found that there is a significant placebo effect associated with these symptom score reductions as patients are filling out a questionnaire. So there's a subjective component associated with this. Then there are the side effects. These are some of the more common side effects that are listed. A lot of these side effects tend to affect sexual function, and that's probably the most common reason men will stop the medical therapy that we put them on. We are also learning about some long-term effects of some of these medicines, adverse effects. These can be things like dementia. It can be things like permanent erectile dysfunction or something called post-finasteride syndrome. And so there's a lot more information that we are learning still about these chemicals. So the current state of BPH treatment shows that about 12 million men are treated for BPH in the US. There are 21% of men that are on watchful waiting. They are simply watching their symptoms, either because they do not want to be on medicines or medication caused side effects. Others may not want to commit to invasive surgery. 62% are on medication, but 1.7 million men discontinue medication due to side effects. But only 3% undergo a procedure to fix their problem. And so the question is why? Why is there such a big gap in patients who have symptoms but seek alternative or additional treatments? So let's look at the history of medical therapy. Medication for BPH really started gaining ground in the early to mid 90s. But these were only a type of band-aid solution on a mechanical problem that often requires a mechanical solution. And so patients learned about the side effects, and started discontinuing these medicines. Also, as physicians, we used to push these medicines a lot more because the alternative was often invasive surgical therapy with also very well known risks and side effects. I always joke with my patients that urologists are glorified plumbers, and so here's your plumbing slide. So the question becomes, do you want to pour chemicals or plumber type solution or medication down the drain, or use a snake and fix the obstructed problem and take the obstruction out of the equation? What does long-term medical treatment really do? We are finding out now that long-term medical management is not as safe as we once thought in terms of bladder health. By putting a band-aid on the problem, our patients' bladders decompensated over time and would eventually fail. The reason that catheter commercials on TV exist is because there are a lot of men in need of this form of drainage once their bladder stops working due to chronic blockage. This is a two-part system type of problem. We have the first part, which is the bladder or the pump, and then the tubing, which is the urethra. Urologists and surgeons have many different tools to fix the tube or the urethra and disobstruct the prostate. However, if the bladder goes bad and gets permanently damaged, we can't really fix that as easily, and they don't make replacement parts for it. These are pictures of prostates and bladder after long-term medical therapy. The picture on the left is a view of a prostate that has grown large enough to block the flow of urine, and medication just simply can't open this up. The middle picture is a view of the inside of a bladder and shows scar tissue or trabeculations that have formed due to long-standing blockage and ultimately cause bladder damage. These thick fibers represent those scar tissues, and those openings or diverticula are another indication of long-standing obstruction and damage. The picture on the right shows a median lobe of the prostate, or an outgrowth of the prostate into the bladder. Again, medications typically can't fix this, and this may be one of the causes of severe urinary urgency. So in recent years, there has been a paradigm shift. Untreated bladder outlet obstruction may lead to permanent bladder damage, and surgery provides the best solution to disobstruct the urethra. But a lot of these surgical therapies we had available came at a price, and so we had to rethink this whole problem. To learn a little bit more about the history of the surgery and most popular and perhaps well-known surgery, um, let's look at who came up with these techniques. Many people in the community are aware of the TURP procedure, or the Roto-Rooter. This procedure was made possible in the 1920s, so almost a century ago, by these urologists who developed the first tool to allow us to resect prostate tissue through the urethra using a minimally invasive technique. Unfortunately, there were many side effects and sometimes massive bleeding at the time due to the limitations of the technology. Our technology and optics are better now, but the essence of the tool has remained about the same. We were essentially using century-old technology to treat patients surgically. What are the surgical management options? Most of them involve removing prostate tissue or damaging, destroying it in some way. Unfortunately, these types of treatments can have serious side effects, but each treatment may be the best option for a certain patient. And so a urologist who has training and access to all of these treatment modalities can perhaps provide the best option to their patient. The American Urologic Association put out this statement a while back. It said, since many men discontinue medical therapy, yet proportionately few seek surgery, there is a large clinical need for an effective treatment that is less invasive than surgery. With this treatment class, perhaps a significant portion of men with bladder outlet obstruction who have stopped medical therapy can be treated prior to impending bladder dysfunction, that permanent bladder damage I was mentioning. So the goal was to get from the left side, from the left obstructed picture, to the right side, an open prostate. We wanted to do this using minimally invasive surgery. We wanted it to be safe, durable, with minimal to no side effects, and not have to catheterize our patients routinely. And patients wanted to be able to stop their medications, stop the chemicals they were taking daily. When patients were asked about what was important to them in regards to a surgical alternative to BPH treatment, these were the most desired features. They didn't want post-operative catheters. They wanted rapid relief and recovery, minimal to no downtime. They didn't want to have discomfort. Preservation of sexual function was very important. Some patients wanted an office procedure or outpatient procedure, and local anesthesia was at the bottom of the wish list. So the UroLift procedure came about. The UroLift procedure was introduced about a decade ago. This procedure, unlike the other ones I discussed, involve placing sutures in the prostate and opening the urethra like you would open up a curtain. So a mechanical solution for a mechanical problem. By pushing the tissue out of the way, a large channel is then created to allow better urine flow. This procedure can often be done once the patient either is sedated or ready to undergo the procedure. It's done in about 10 minutes, at least in my hands. The procedure is done by placing a small camera into the urethra where the prostate is located, and then deploying these sutures that have tabs on either end of them, and these tabs are then secured so that the prostate is essentially squeezed out of the way, similar to what you would do with a zip tie perhaps. UroLift was thought to bridge the gap between medication and invasive surgery, and I would now argue that it can even be used as a first-line treatment due to its great safety profile. Medications, like I mentioned, have significant side effects, and those side effects accumulate sometimes over time, and we are still learning about more of the long-lasting side effects of these medicines. These medicines also affect every cell in your body, and so they can therefore cause various different symptoms and side effects. And not all patients will experience the side effects, and not all patients will experience them at the same intensity. It is the only procedure, UroLift is the only procedure that has not been shown to cause erectile dysfunction or retrograde ejaculation, which was one of the things on the wish list when we asked patients for what they were looking for. Now, there are several centers of excellence for this procedure around the country. A center of excellence designation is directly given to the individual surgeon who has achieved high level of training and expertise with the UroLift system and has demonstrated outstanding outcomes. I'm fortunate to have achieved this designation at Mon Health Medical Center. The national data on symptom improvement after UroLift by a center of excellence surgeon is about 40%. My data surpasses that by almost double at about 76%. And these are symptom improvement scores, so AUA symptom score that we administer before the procedure and 4 weeks after the procedure. And these are the percentage improvements in those numbers. The evaluation of BPH when considering a surgical treatment adds a couple of things. One is a cystoscopic evaluation, which is a small camera placed into the urethra down to the prostate. And that's done in the office, doesn't require anesthesia, takes about 2 minutes. And that allows us to evaluate the inside portion and the blocked portion of the urethra. We also perform a prostate ultrasound that allows us to see how big the prostate is on the outside. And between these two additional tests, we are able to determine if a patient is a candidate for UroLift or some other procedure, and we can counsel them on what needs to be done. I compare this often to when your ear hurts, somebody looks inside your ear before they administer medication or treatment. This is the same thing when your bladder is not working right. We want to know why, and we want to make sure the diagnosis is correct. So therefore, we look inside with a small camera. Also, there are other diseases that may manifest that have symptoms similar to BPH but are more serious, like bladder cancer. The UroLift procedure at our hospital is done as an outpatient procedure. It takes about 10 minutes once the patient gets some twilight type anesthesia. It can also be done with local anesthesia while the patient is awake, but can be somewhat uncomfortable during the implant placement. We do use certain modalities to make patients comfortable if they choose to do it under local sedation. I also use a virtual reality distraction type of technology that's only done here at Mount Health Medical Center. And that tends to be a very big hit with our patients and does do a great job of distracting them during the time of the procedure. Majority of patients go home without a catheter. About 10% of my patients go home with a catheter, depending on what we see intraoperatively, and they see us in the office the next day to have it taken out. There's often a period of 3 to 14 days of urinary urgency and burning with urination, a little bit of pressure sensation in the pelvis that patients may experience, and I provide my patients with certain medications during that time for comfort. Here's our contact information. You can visit our website for more information as well. I also have several social media accounts where I post about helpful topics on a routine basis, so feel free to register and subscribe to those. My personal website, radroboticsurgery.com, is also listed here, which contains a health blog where I discuss various urologic health topics and I update them on a fairly regular basis. I hope you found this presentation helpful. And if you have any questions regarding this topic or would like to come see us, feel free to call us to make an appointment or visit my website. There's a contact form on there as well. If you fill it out and send me a message, often I get back to you directly and I can answer some of your questions. Thank you for taking the time to watch this webinar.